Now, switching gears a little bit, what about those patients who cannot go to a stem cell transplant? Do we treat them any differently? The reason why we often think about them differently is because as older you get, you have more comorbidities or other illnesses like hypertension, heart disease, diabetes, kidney problems, all of which can be made worse by the treatments that we give. Now, the osteoporosis can be made worse because of the steroid medications. All patients are often, again, more frail. They don't metabolize drugs the same way. They often have social support issues, financial problems, limited mobility, and so forth, which can determine what kind of treatments that they can get and how often they can come into the clinic. For the long time, we used a three-drug combination, just like we used in the transplant-eligible patient population, the same medications of bortezomib, lenalidomide, and dexamethasone, but given in a less intense manner, each cycle being 5 weeks instead of 3 weeks. Lenalidomide given at 15 milligrams instead of 5 milligrams. So with this approach, the patients are able to tolerate the treatments better and they seem to get the similar outcomes. More recently, when these monoclonal antibodies like the daratumumab came along, we combined that with the lenalidomide dexamethasone and did a large trial looking at the 3 versus 2 drugs. What we found was that in the Maya trial, if you use the 3-drug combination, including the monoclonal antibodies, patients had myeloma under control for a much longer period of time compared to just using 2 drugs. In fact, nearly half of the patients had the myeloma under control past 5-year time mark. And now, more recently, studies have looked at replicating the same results as in the transplant-eligible patient population by using 4 drugs instead of 3 drugs. Now, this is a randomized trial that was reported out in the past year, where they randomized patients to getting the bortezomib, lenalidomide, dexamethasone combination or the monoclonal antibody added to it. This trial showed that patients do get a deeper response, a better quality of response with the 4 drugs, and they were more likely to be MRD negative or minimal residual disease negative. And this translated to better progression-free survival compared to the 3-drug combination. Another similar trial, instead of using that monoclonal antibody called cetuximab, used daratumumab, but very similar design, 3 versus 4 drugs, showing similar results with a higher proportion of patients getting a deeper response or MRD negativity compared to 2 drugs, and also having a better progression-free survival with the 4 drugs compared to the 3 drugs. The overall survival appears to be quite similar at this point, but we don't know. With time, we might see that the 4-drug combination is actually allowing people to live longer. So in general, what we have been doing is that if you have transplant-eligible patients and they are standard risk, we would give them 4 cycles of the 4-drug combination, the DARA-VRD, in all patients. We have switched from doing the VRD to DARA-VRD in everyone. If you have high risk, then we would take them to transplant early. And if they're standard risk cytogenetics, then we might collect the cells and have the option of going to transplant versus delaying the transplant. If you have transplant ineligible, we tend to use either, again, the 3-drug combination or the 4-drug combination, depending upon the ability to tolerate the medications. Now, as important as these specific therapies aimed at getting rid of the myeloma cells is the supportive care. Patients are often immunocompromised at the time of diagnosis. Their immunity is low. They can get infections. We often put them on antibiotics for the initial 3 to 4 months to reduce the risk of infections. When patients are on steroid medications, they can get infections with certain unique organisms like pneumocystis. So patients are often put on Bactrim to avoid that particular problem. We know that bones can be affected by myeloma, so we give medications like zoledronic acid, denosumab, along with calcium and vitamin D to ensure that the bone strength is maintained and improved. Patients can develop thrombosis or blood clots while they're on these therapies, so we often put them at least on aspirin and sometimes on blood thinners if they're at a high risk of developing blood clots. So with that, I'll stop and thank you so much for your attention.